Welcome, everyone. We're going to give it just a moment to allow everyone in from the waiting room, and then we will get started. Thank you all for joining today's webinar. I'm Lori Benner, Associate Vice President of Housing and Community Development with the National Fair Housing Alliance. In recent decades, the healthcare and housing fields have increasingly acknowledged the importance of social determinants of health while working to improve health outcomes. Health and housing advocates have shared an understanding that place matters and not every neighborhood offers the same opportunities for people to thrive. Too often, because of our nation's entrenched history of housing discrimination and residential segregation, people of color are less likely to live in places that provide the optimal conditions to lead to a healthy life. Last year, the National Fair Housing Alliance engaged with health management associates to engage further on these issues. This afternoon, we'll hear more about that work and how health and housing practitioners can tackle the health inequities linked to segregation and race to ensure that every neighborhood is a place of opportunity. This webinar will be recorded for later viewing. We'll hear two short presentations from each the housing and health industry perspectives. Then we'll have a moderated panel discussion, and we'll wrap up with audience Q&A. As you listen to the conversations and presentations, feel free to drop your questions in the Q&A box, and I'll pose them to our guest speakers at the end. Today's presenters are Shanti Abedin, Vice President of Housing and Community Development with the National Fair Housing Alliance, Maddie Shea and Letitia Reyes-Nash, both principals with Health Management Associates, Gretchen West, Executive Director with Healthy Homes, and Kimberly Harris, Director of Community Health with Care First Blue Cross Blue Shield. And with that, I will go ahead and turn the mic over to my colleague, Shanti.
Sure. Hi, everyone, and thank you so much, Lori. I just wanted to open up by just telling you all a little bit about the National Fair Housing Alliance. For those of you who are new to our work and our organization, we are the leader of the National Fair Housing Movement, civil rights organization that works to eliminate housing discrimination and ensure equal housing opportunities for all people. And we do that in a number of different ways. We do education and outreach. We do member services with our members all over the country, many of whom are on this call today, public policy and advocacy work, housing and community development work. We do a lot increasingly now in the responsible AI realm, and then enforcement and consulting and compliance programs. And so I wanted to open up our discussion today, just doing a little bit of grounding in the key concepts that we'll be focusing on today with regards to housing equity, fair housing, and all of its connections to health. And if you've attended any of our NAFA events or webinars before, you've probably heard us talk about this concept of where you live matters. And so this is the key idea that sort of grounds the way that we do our work in communities. And the idea is that housing and where you have access to housing affects all these other aspects of your life, where your kids go to school and how well resourced those schools are, what kind of jobs you have access to, what kind of transportation serves you, and whether you can breathe clean air, drink clean water, and what opportunities you have even to build wealth, and a whole host of other things. So you can see that sort of illustrated here on the screen. And housing discrimination, has health impacts on the individual themselves. The housing unit that they're in has health implications on the person and the family and the house that they're able to obtain. But then the community, this whole aspect of where they live, is really a huge driver. And we hear folks say that, you know, your zip code is a better predictor of your health than your genetic code, right? So there's a whole, framework here um, that dictates kind of where you have access to critical resources and amenities. And we know that that is not equally distributed across our communities. So we often have that communities of color really get the short stick when it comes to amenity-rich neighborhoods and access to all of these things that make the quality of life better. And that has not happened by accident. So we know that centuries of race-based policies that were explicitly designed to discriminate against people on the basis of race have a long legacy in our country and have perpetuated segregation for decades. And much of this was actually perpetuated by the federal government, right? So going back to our Constitution through the Jim Crow era, Homeowners Loan Corporation, the National Highway Act, which divided neighborhoods during urban renewal. And all of these things were paired with practices in the real estate and housing industry, racially restricted covenants, and they've all really created this landscape of segregated communities that have inequality embedded in the way that that the people can live in them, right? So I just wanted to make sure that we were grounding our discussion in that history and in that context. And so as a result, we see these disparities play out in a number of different ways. We're going to focus a lot today on the health aspects, obviously, of these disparities, but all of this is related to one's health and well-being. So we see that people of color are twice as likely to live in food deserts across the country. So not having a grocery store in their area, 5 times more likely to be unbanked, 71% more likely to pay more for broadband or internet access, twice as likely to be impacted by environmental justice issues and live in areas without potable water or proper sanitation. Schools that are predominantly white in white school districts receive about 23 billion more in investments each year than schools in non-white districts, even when you account for the amount of students in those schools. And then we also know that pollution is a big aspect of this too. So Black people are 3 times more likely to die from pollution related issues than their white counterparts. So just wanted to also ground us in how stark some of these disparities can be. And overcoming these disparities, which is what we're really all here to talk about today, particularly in the space of health, requires us thinking about changing with an equity framework. And so that's where we can really look back to the Federal Fair Housing Act, which was passed in 1968. And the Fair Housing Act was passed with a dual purpose. First, it made housing discrimination illegal. So it made it illegal to discriminate on the basis of race, religion, a number of other things. It also acknowledged our deep history in residential segregation and the harms of housing discrimination. And it put into the act a provision called the Affirmatively Furthering Fair Housing provision, which ensures that federal agencies administer their housing and community development programs in a manner that advances fair housing. So in other words, it accounts for eliminating the systemic discrimination and remedying the harms that were caused by housing discrimination and segregation that we see in our neighborhoods. And so it's an equity-based framework that communities can use and are mandated to use if they receive federal funds in the housing and community development space. And it's a planning process that has community engagement, cross-sector engagement, and can really be a powerful tool to ensure that all people in all communities thrive. And so a little bit more about how it works. I mentioned it's part of the Federal Fair Housing Act. It requires all federal agencies programs to have their participants affirmatively further fair housing. So folks who receive funds from HUD for community development purposes and housing purposes have to really participate in this process. And what it does really is requires jurisdictions and others who receive those funds, public housing authorities, et cetera, to conduct an analysis, which they have to do every 3 to 5 years, depending on the type of entity they are. And that analysis identifies barriers to fair housing. It develops solutions to overcome those barriers and provides for a way to monitor that progress. And so one thing I'll just mention too is that it's been a tool for us for 56 years because of the Federal Fair Housing Act, but it's been widely underutilized. And just to give a really, really brief history of the rule. So for the first 27 years after the Fair Housing Act was passed, there was very little guidance from federal agencies around how to implement this mandate. But then over time, we've received additional guidance, like, for example, putting these plans together. And then early last year, HUD proposed a new rule for AFFH that strengthens it and makes it increases the accountability for it and increases the effectiveness of the tool. And so we are anxiously waiting that proposed rule to be put into practice. And it requires a few improvements on the existing process, including the development of this equity plan, more frequent progress reports, specific guidance on community engagement, the ability to ensure compliance and enforce the AFFH requirement. And one thing it really specifically does and has a lot of language about is encouraging the linkages to other plans and other sectors to achieve these goals. So including spaces of health, environment, et cetera. And so the topic of today's webinar really stemmed out of that encouragement to, or that requirement to link to other plans and link to other sectors. And really, we want to understand how we can better connect this process and similar housing processes that are focused on health outcomes to better achieve the goals that communities have set out for themselves and that we are all looking to support. So we found often that health equity advocates, health systems, healthcare providers are often working to serve the same neighborhoods and the same communities that the AFFH mandate is focused on. And they're focused on advancing the same, or kind of closing the same gaps, if you will, for the same people. And so this need for these processes to come together to advance the same goals in the same place is essential. And so we engaged the health management associates here to help us explore this intersection further. We really wanted to just kind of point out here that the social determinants of health in the health space overlap a lot with the way that we think about this where you live matters. We have a house in the center and where someone lives, but it's really, reflected in the social determinants of health as well. And so I am going to pass it over to Letitia and Maddie to take us to the next part of our exploration of this intersection.
Thank you so much, Shanti, and thank you for outlining the AFFH process. This is a really exciting time in health, and I think that we were excited for the opportunity to partner with NAFA on this because there is such an opportunity to align our efforts. Thinking of our needs around place-based approaches. And we have lots of needs assessments and other processes that are happening in community. And we really want to maximize the opportunity to get to leveraging our assessment processes and our processes to identify what the needs are in community and really start to strengthen the action planning and the action components of all of these great assessments and planning by thinking about ways that we can align our efforts both in the health space and in the housing space, because we know housing is health. It's a critical element for health and for the health of our communities. So in the report, all of these areas are talked about. I'm going to zoom in on one area, which is the Medicaid health plan space, and my colleague Maddie is going to focus in on an intersectional space, which is zoning. Next slide, please. So right now, there are so many different opportunities where we're seeing an integration of thinking about housing and housing supports within the Medicaid program. And so right now we have a significant amount of efforts happening specifically around 1115 demonstration projects. Those projects are including housing and connection to housing. So it's primarily focused on identification of individuals who have housing needs, and then working to connect them to the appropriate housing supports. There's also, for those who are in housing, services that are going to be funded to support individuals in those housing spaces. And so right now we're seeing an opportunity. These 1115 demonstration waivers are just that, they're demonstrations. So we really have to, in these projects, really demonstrate that this combination of alignment of the screening and identification of individuals who have housing needs are not only identified, but also linked to the resources and services that will help them, whether it's the prevention of losing housing or it's staying within the housing. It's a big area of opportunity to be thinking about. We have a number of health equity investments that are coming from health system partners around, and we'll hear of some of those examples around identification of need within community, and then investments in capital stacks and actually building new housing in some communities. That is not supported by Medicaid. That's being supported by place-based strategies that are happening in the health care sector and by place-based health systems who are often anchors within their community. And then just to mention here, this idea of comprehensive risk assessments. Right now, we have a requirement that's continuing to emerge that's happening both in the hospital setting around screening for health-related social needs in the inpatient setting that's being required by CMS for that to be happening, or if it's screening and identification for the needs within those who are receiving services in the Medicaid program through the health-related social need waivers. So right now we've got a lot happening in the health market where I think there's a lot of opportunity to partner with fair housing partners to really, again, align our efforts more strongly so that we can look at all the needs holistically for communities and work together with community to develop strategies and also have opportunities for reporting back on the impact of our alignment and our work and efforts. Next slide. This is just a quick snapshot. We have 19 approved waivers that are addressing housing needs. Take a look at the states that are listed here. I would invite you, if you haven't been engaged in the process around this work that's happening in these states, and this is one of your states, I would encourage you to learn about it. There's lots of opportunities for providers and partners to provide input and feedback. But at the end of the day, the implementation is where we're going to have a lot of opportunities for partnership. And I think that if you are in your community and you're in the fair housing side of the house, I think the health partners would be welcome the opportunity to have you come to the table as part of those processes around implementation for these supports. And while these supports that are coming from Medicaid right now are really focused on the populations that are listed here on the slide, we know that there's a large continuum of need around housing. And so that is the bigger picture that I think a lot of the fair housing agencies can bring to the table for healthcare. So thinking about the whole continuum of housing all the way to, identifying opportunities for home ownership and moving to creating wealth building in communities, we really need to think of that full continuum in order to be able to effectively serve the communities that we're in. And so, again, I think healthcare is really open and interested in your engagement as we're going forward and implementing these new innovations in the Medicaid program. And your expertise, I think, will be really valuable at these tables. I'll turn it over to my colleague Maddie to talk a little bit more about an intersecting strategy between health and fair housing.
Thanks, Letitia. So these are all about infrastructure rather than a policy or strategy. because the infrastructure is actually critical to our policies having the impact that we want. And in the report, which we encourage you to review, we look at 3 different areas: zoning, transportation planning and investments, and environmental justice. These are all real big areas. An example for, we're going to get into zoning, but for transportation planning and investments, you can think of complete streets. That's where, you know, whether there's bike lanes, places to be safely active, or where bus stops are, or other transit stops, safe crossings. You know, we had a huge increase in pedestrian fatalities during COVID. And so this ability to have a place to cross the street. And then environmental justice, as Shanti was telling us, includes everything related to clean air, clean water, extreme heat, flooding, as we're seeing now in our country. It can include noise, but these are all really, there's people, these are really important to health, as well as fair housing also is the context in which it's in, the community it's in. It's not just within your walls of your house. So let's go a little bit deeper into zoning. Zoning is an area where I had the good fortune to, we can go to the next slide, to get involved in a really deep way when I was working in the Baltimore City Health Department. But zoning, well, let's start with who's at the table making zoning decisions. So you have zoning advisory boards or something like this with some name like that at the local level. And who would you imagine sits on those boards? It's developers and their lawyers. That there were no health interests ever involved in Baltimore before I was the one that drew the short straw and had to participate in those meetings for 2 years when we were writing a comprehensive new zoning code. But that was so I got to learn a lot about it and who participates and how the power is stacked. So that's why we're bringing this up. Because zoning will impact housing density, the use of land, whether it's commercial, whether it's industrial, whether it's transit oriented. So the use and the density, so residential, commercial, and so that shapes everything that's in the built environment ultimately. And you've probably heard of exclusionary zoning, because right now, a big issue in the country that our presidential candidates are speaking out about is that we have a really desperate need to expand affordable housing. And one of the barriers to that has been exclusionary zoning. So that's not allowing for higher density or accessory dwelling units. So you could put a little house for a family member on your property, or split up your house to have an extra unit or apartment in there for someone. Zoning is what restricts that. So there's an interest in looking at ways to make it inclusionary zoning rather than exclusionary. So just bringing up that. But it does ease restriction for things like licensed residential care facilities. Healthcare organizations care about this, as well as housing and community development interests. Also, it will impact transit-oriented development to reduce sprawl. The example I'll get more into is in Baltimore. We looked at using zoning to decrease the density of alcohol outlets to reduce crime and neighborhood safety, which was the biggest problem, you know, through a community engagement process. This was top of mind for everyone, including those developers on the zoning board, incidentally. And then it also can allow for a range of housing types. because a lot of times we have the exclusionary zoning would say it has to be so big with so much property around it. And that was very much meant to exclude certain people from certain neighborhoods. So this example in Baltimore that's written up in the report is we looked at a bunch of the biggest health priorities for the city and what could zoning impact the most. And there was more than one thing. We looked at nutrition, access to good food, nutritional food. As Shanti was mentioning, access to grocery stores is one thing. But we thought that the most cross-cutting issue we should focus on was crime and violence. Baltimore has a bad rep for this. And it also is cross-cutting. There's no one who would say they don't want to decrease crime in Baltimore. So we did some modeling to identify that we could really reduce crime dramatically and all the costs associated with that, including health costs, by not allowing actually by closing some of those corner liquor stores. I don't know if you have those in your communities, but we certainly have them in Baltimore. And they're places where there's a lot of gun violence and where children walking home from school are exposed to violence. And through a year and a half of working with that zoning board, and so that means you have to really get in and get to know people. You can't drop in on the day you want them to do something. It was a commitment. We were able to get the whole new zoning code rewrite to include this new restrictions on use, on land use to restrict, so that there wouldn't be high density of liquor outlets. And so they did agree, and that went into place. So that's just an example of a powerful thing that you can do, but there's many, and having health interests at the table is really critical here.
Okay, at this time, I'd like to invite Shanti back to the screen, as well as Gretchen and Kim for our panel discussion. We'll go ahead and start off with a question for you, Gretchen, and please, you can, before you answer the question, tell us, or part of the question, tell us a little bit about your organization and the work you do. But Healthy Homes was born through a partnership with Nationwide Children's Hospital. Can you describe the community needs or issues that gave rise to the larger collaboration?
Yeah. So first, hi, I'm Gretchen. I'm the executive director at Healthy Homes. I'm actually also a hospital employee. And so we were born, I guess, in 2008. We started our work in the neighborhood directly south of the hospital's main campus, so right outside our front doors. And if you recall back to 2008, the entire country was suffering the effects of the subprime mortgage crisis. And that neighborhood, Southern Orchards, was no different. And by the time our work really started in earnest in 2009, about 1 in 4 houses in our neighborhood was vacant. And beyond vacant, because of the various flipping happening and investment, a lot of those homes were in really bad shape. So it's also an important time for our hospital. In 2008, the hospital had announced a $1 billion campus expansion. And our CEO at the time, Dr. Steve Allen, said that if we were going to become a world-class hospital, which was the aim of the expansion, we had to be world-class neighbors. And so we started our investments by buying the worst of the worst homes in that neighborhood, fully rehabbing them, and then offering them as affordable home ownership opportunities. We then coupled that program with a home repair grant program for people who own and live in their homes to make sure that the people who had always been there could also benefit from our programming. And then for 8 years, that's all we did, those 2 programs. But in 2016, our work had to shift again because the market was shifting. Private investment was coming back. And as a result, housing pricing was going up. And so we then started to buy homes, rehab them, and rent them at affordable rates. And these days, we do more rental than homeownership. And what our research tells us is that children have a really hard time succeeding without a stable, healthy home. And of course, I love all of our programming. I'm the executive director, but I think the rental piece is where I see us having the most impact by providing high quality housing for some of our most vulnerable households. And this work for us is more important than ever. Between 2017 and 2022, Columbus saw rent increase by 34%. And now, for every 10 families who need an affordable place to live, there are only 3. And so we're doing the best we can to respond to that by building homes as fast as we can.
Great, thank you. Now, Kim, same prompt for you in that feel free to expand a little bit on your work there. But Care First has supported housing in Baltimore City. Can you tell us why a health insurer would invest in housing? It looks like Kim might be frozen. I'll pause just a moment and see if she can come back with us. Okay. Well, I will skip on to the next question. Oh, there she is. Hi, Kim. Were you able to hear the question that I posed?
I know the question that you posed.
Okay,
I'm
great.
so sorry. We didn't have any problems before that. But thank you again for having me on the panel, and thank you for this very important conversation. Care First Blue Cross Blue Shield is one of the nation's largest not-for-profit healthcare organizations, duly headquartered in Washington, D.C. and Baltimore, Maryland, serving about 3.5 million people. I have the privilege, I think Gretchen said it best, like I love all these programs. And so I'm very familiar with that. I do have the privilege of overseeing Care First philanthropic investments across the region. We address access to care and also those social drivers of health that have been mentioned earlier, those non-clinical factors that impact overall health, such as transportation, of course, housing, and food insecurity. And so what we knew for sure is that if 80% of someone's overall health was affected by those non-clinical factors, and I think Shanti said earlier, knowing that your zip code is a predictor of your overall health, we knew we had to do more. And so as a result, economic inclusion and development became a priority area for Care First. And that was actually when I knew that I was going to stay at Care First for a while, when our CEO, Brian Pinnock, said, somebody asked, why is Care First, a health insurer, involved with economic inclusion and development? And he said, we got to do what's right, not what's easy. And so we released $2.2 million to address the racial wealth gap, significant differences of life expectancy across short distances, and creating opportunities for everyone to thrive. While we provided funding across the region, Parity Homes in Baltimore was one of our recipients that received funding for the Home is Where the Heart Is initiative, and it transformed abandoned buildings to beautiful home ownership opportunities. According to the 2023 County Health Rankings, 21% of Baltimore City households experience one of the following housing problems, like overcrowding, high housing costs, lack of kitchen facilities and plumbing. And that's higher than what we see in the state as well as what we see in the nation. And so when we look at affordable housing for Care First, it's not just about affordable housing, it's about quality housing, and then being very intentional about the other services that we bring to families. We don't want to solve one problem and create another. And then also what partners need to be at the table. So we do provide a comprehensive approach. And so we look at investments from supportive housing to home ownership, but also sort of those, I always say, stacking the resources. What are the other resources that are required to address some of those social determinants of health, along with affordable and high quality housing?
That's great. Thank you. So, Letitia and Maddie, HMA works with health related institutions, organizations all over the country. Do you see any themes in how these entities are thinking about or engaging with housing providers?
Yeah, I mean, I think and I'm super excited to be on the panel with my colleagues here because I think there's a couple of things. I mean, I think in the market, there are those who are kind of the early starts who engaged in this game and housing and saw that health-related social needs and place-based interventions were a key priority. And so there are those institutions and organizations that have been doing this. They've been building buildings, creating capital stacks, leveraging, their funding to bring down additional funding to help build affordable housing, addressing the needs of unhoused. But now we're in an environment in which the federal government is requiring our health entities to think about this. And so this is what I think, is different than it was, just 3 to 5 years ago, is that, this was like an emerging area, but now there's accountability that's being brought through. And so we're seeing that through the health equity kind of strategy across the federal government. We're seeing that through the CMS requirements, which are requiring screening for inpatient settings for health related social needs. Now, we're having a lot of requirements around screening and identification within Medicaid health plans. We have the opportunity to read the procurement for Medicaid and Medicare Advantage health plans all across the country, and across the board, you're seeing, how are you asking the explicit question? How are you partnering with housing agencies? Who are the community-based? What's your network of community-based organizations, and how are you working with them? How are you determining that you're addressing those needs for those individuals? And so the market is reacting to the requirements that they have around this. And similarly, we had the CHNA, the community health needs assessment requirement from the IRS for hospitals. But I think that we're moving to this, what I would say, a 2.0 phase of this work, which is moving towards having accountability. So it's not just I have an idea, let me do a partnership. We're going to be held accountable for outcomes. And so I think that in this moment in time, we have this moment right now to actually think about how do we align our systems in our various partners who are doing similar work in our communities who are addressing health related social needs, and how are we aligning that to then show impact? Because if, as a community member, how many times can you assess my community and come up with the same results and not have a better outcome for my community? It's time. Like, now we have to align, and we need to show that we're actually improving. We're demonstrating that what we're doing and the actions we're doing are improving health outcomes for the people we serve, and that the people we serve feel that we're accountable to them. And so I think that's the 2.0 phase that we're moving into, and I'm hopeful for going forward. But Maddie, I would love to hear your thoughts as well.
So Letitia told us a little bit about Medicaid and how Medicaid waivers were impacting this. Well, there's 3 elements of those where you see a lot of action. Those waivers target housing stability. So pre-tenancy, to get people into housing who have either been homeless or who have been unstably housed. And then once they're in housing, supports to stay in housing. And California has going online now 6 months rent may be paid through Medicaid, and that's newsworthy for justice involved people who are getting back into the community and others, the 6-month rents. So another area that CMS has allowed for in those Medicaid waivers is housing quality. So we heard about how important that was and what's going on in Columbus with Nationwide to kind of balance out. Building new housing takes a long time, so it's good to have strategies that can be short and long term. And that focus has been on housing modifications to help people, older adults, people with disabilities, not to have injuries largely, or to be able to access housing at all. So those are big areas where I think we see a lot of action from healthcare organizations, in addition to respite housing, which has been all the rage across the whole country. So that's helping homeless people who are being discharged from hospital to have a place to recuperate, you know, other than the street where they're gonna be right back in the hospital. So that's another big area.
Thank you for that. Now, Gretchen, the city of Columbus recently updated its zoning code for the first time since the 1950s. Which of these changes do you see having a positive impact?
Yeah, actually, it was just a few months ago, so we're super pumped to start building some more housing. So Columbus chose to focus on the commercial corridors, and so it's really only about 5% of Columbus's parcels, but just unlocking that 5% will allow up to 88,000 units of housing to be built. And this is at a critical time. I think what I said before, we are growing at an exponential rate, bringing in 1.4 people every day to Columbus, and we need places for these folks to live. And so one of the things that I like most about the new code is it really opens up some of those more affluent neighborhoods that have been NIMBY to date and have made every effort to quash development ideas and allowing them to build projects without having to go through a rigorous process around height and parking requirements. But it doesn't stop at housing. It also creates the condition for smart, sustainable, and equitable growth that can unlock economic and development potential of our neighborhoods. Because I believe that strong commercial corridors lead to strong neighborhoods. And I want to say that the hospital and Healthy Homes are a part of an advocacy group in Columbus called the Affordable Housing Alliance of Central Ohio. And so the hospital was a part of those advocacy efforts to get the zoning code changed. And we're not done. We got to go further into the neighborhoods, but I'm looking forward to what's next.
That's terrific. Shanti, how does using the AFFH framework help guide processes like zoning or infrastructure investments, help put a finer point on moving towards more equitable outcomes?
Yeah, thanks, Lori. I would just say that we're talking a lot about, housing solutions in communities, whether they're to increase the supply of affordable housing in different neighborhoods or, to fix up housing stock specifically. And, health systems are and health entities are very invested in those strategies because of all the things that we've heard folks on this call talk about. And, I just want to underscore that AFFH is and the fair housing planning process can really embed and assess an understanding of the impact on different people, people of color in the community, people who are members of protected classes. So if you look at an analysis of impediments to fair housing for a particular area, you can see that it provides an analysis of the goals around fair housing and can often identify like gaps and blind spots in a housing strategy or in a health, community development strategy that maybe hadn't been explored in the process of developing that particular plan in this other sector, just because we are so siloed. And so often those plans can identify gaps and blind spots. As I said, they often have strong data that has been put together with this fair housing and fair lending and fair communities lens. It's often disaggregated data that you might not get in other places because it has this lens focus or really strong focus on racial equity and other types of equity. And it sets out community-driven goals, which are often overlapping with the goals of other folks in the health advocates and folks in the health space. So, I would just underscore that it provides a different level of analysis that can really come together with work that's going on in other sectors in the same neighborhood. And, for example, with the zoning in Columbus, the AI in Franklin County and Columbus identifies, different steps that can be taken in zoning reform that really help people with disabilities and the process for people with disabilities to request reasonable accommodation. So that's like one small example, but often like the solutions are already outlined in plans. They've been, kind of brought up from communities and can be incorporated in these processes that bring together larger groups of people to, improve housing and health outcomes in jurisdictions.
Thank you. So, Kim, a big theme that we've heard throughout the conversations today is around partnership. Tell us about Care First's approach to community partnerships.
Yeah, so partnership is actually one of my favorite things. I think everybody says it all the time. I think it for two reasons. One, you don't have to know it all. You can call your partners and you get to do the work together. And so, at the risk of sounding cliche, when I think of partnerships, I think about I get by a little better with my friends, better together. It takes a village. In the philanthropic space, if I can be honest with you, money can't buy you love. Sometimes, with partnerships, especially when you're providing funding, it could be very much rooted around sort of the funding opportunity or an event. And we really would like a long-term, year-round partnership so that when things come up and opportunities become available, it's not, associated just in this point in time, but I can say, hey, we're trying to get a school on board to do X, Y, and Z with housing. Do you know someone? And so that makes the partnership, a little stronger. And I tend to lean in on the relationship first. And we know we need resources and the funding will come. But, we have those tried and true partnerships. We have new partnerships. Looking at unconventional partnerships, I think that what got us here won't get us there. And how do we take a multi-sector approach and have, more diverse partners that we wouldn't necessarily have invited to the table. So we can have that alignment that someone mentioned earlier, but also, not being afraid of, really trying to lean in on what the impact could be. I think sometimes with KPIs and evaluations and all those grant requirements, people get a little nervous about that, but really leaning in, to the partners. And as we look at funding opportunities, we're also looking at who can we invite to the table with a smaller organization that does this really, really well with a larger institution that has a good grant writer. And so, not being limited in our thinking in terms of partners and really getting in spaces and hearing from others because we don't have to do it alone.
Great. And now we have a secondary theme, and those are Beatles songs. So, panelists, feel free to weave that into your final response before we get to our audience questions in the Q&A. So I'd like each of our panelists to comment on what's one takeaway you'd like to leave with the audience about how health and housing entities can better collaborate. So I'll start with our HMA friends.
You want me to start, Letitia? I want to grab the Beatles song. Oh dear. All we need is love. And I'm gonna second what Kim said, that I think we committing to that long-term relationship, not just after one grant or on either part, but committing to getting to know each other. So that you really understand about shared goals and areas of alignment. Going out to breakfast once every month or two over a long time, I think is just so important because there's a lot of learning to do about each side of it. So that's what I would say. And in the zoning example was a really good case because none of us in health really understood how that worked until we got into it. It was a long-term commitment. It was very tedious, I will say, but it was worth it. We got what we needed. So that's my advice.
Thanks, Maddie. And just to kind of pick up a little bit of Kim, what you were saying, which is, we have to come, we are in the middle of a housing crisis. I don't think that's something that is understated. I think most of us would agree. And I was in a meeting last week and someone's like, Letitia, we have to throw the whole table at it. Like we've got to and that to me means that we have to have the full systematic picture of what we need to do. And it's difficult because I think when we think about the whole problem, it can be overwhelming. But the reality is that there are many partners and many folks within our communities that are taking on pieces of the puzzle. But the missing component is the alignment and connectivity of everyone churning away on those little pieces. And so and actually those pieces are not small, they're all pretty big, but in order for us to actually get to solving, if you will, the housing crisis, we have to go beyond kind of our limited kind of scope and push ourselves out of that comfort zone to see that full picture and to partner with those folks who are in all those different pieces and really come to a consensus around is the outcome or the goal that we want, and really having that be driven by our communities. And so I think that we can't underestimate the moment that we're in this time in which we have to align and really to be able to strengthen our ability to solve these really, really difficult challenges that we're facing. And so I think right now, healthcare is very amenable and open. They're not always the easiest to engage. Our health plan friends, I mean, there's not always a phone number like partner with me on their website. So it's not always that easy. But I think that that's where I think we all together having more holistic approaches to our work will lead to better, more impactful outcomes. And I think there's lots of demonstrations of that across the country and some bright spots that we've highlighted in the report.
Great. Shanti.
Well, I guess I'll just say we can't just let it be. I don't know. I couldn't think of another Beatles song at the top of my head, but no, we have to really consider, the necessity for us to acknowledge, the racial elements of, like the racial equity elements of our plans here. So we need the fair housing planning process to help us identify that framework. And specific goals that really center equity. I think often we think that, improving the number of affordable housing units, like I said, or, taking some of these strategies will automatically help communities of color and people of color, but it won't unless we put a really more intentional lens on, how we're doing that, engaging communities and identifying how that actually happens, and really doing an analysis of the data that we have and and understanding the how the strategies that we have might impact different groups of people. So I think just having this additional framework on top of all of the systems that are in place to really, really hone in on specific ways that we're addressing and accounting for housing goals is just an essential piece of the puzzle. And if we don't do it, things will continue to kind of go by the status quo, right? We have to kind of be more intentional about disrupting the way that resources are flowing into our communities and the way that we're addressing our health and housing issues.
Absolutely. It's important that we all come together on these issues. So, Gretchen.
It's hard not to agree with Kimberly and what she was talking about in terms of partnerships. They really are critical because we can't solve this alone. And I think part of that is beginning with communication. Healthcare and community development love their jargon, love their acronyms. We got to learn how to speak the same language. And then when I sometimes talk to other hospitals, I think hospitals have to make a better effort of going into communities and not just like studying them, but also coming back with real solutions. And so, there is a big difference between like an authentically engaging with communities versus waiting in your ivory tower for a community to come to you.
Great. And Kim.
It's hard going last. I think my Beatles song would be, Don't Get Weary on the Long Winding Road. This is, and also how can we be more innovative and bringing friends along the way, sing a couple of Beatles songs. But it's tough when you're doing this work, all the time. And we talk about move the needle and do these things and that, and we'll see these improvements. And my previous job, I did work at a children's hospital. And for years, it was the stat was 8 out of 10, and it was like 8 out of 10 for the second year and the fifth year and the 10th year. And so sometimes that can be daunting. And so we just have to remind ourselves not to get weary on that long, windy road. And how do we get more innovative? I remind myself a little story, Formula 409, the cleaner. The reason why it has the name is because it took them 409 times to get it right. And so, I think about it like, what if I stop at the 25th time I tried, or the 28th time, or the, 407th time? And so, keeping that sort of momentum going and calling on your friends, our partners, when you do get a little weary.
That's terrific. Thank you all for just playing along with that. You're such good sports. So at this point, we'll turn our attention to the Q&A, and I do see that there's been a couple of the questions that that our panelists have typed in answers for. So I'll just kind of head down the list because we do have a bit of time here. So this question is for Gretchen. As a hospital system, what expertise did you need to bring on board to initiate your Healthy Homes program, and what funding supports Healthy Homes?
Yeah, Healthy Homes began with two people, and I was one of them as an AmeriCorps Vista worker. And they had hired the inaugural executive director from another nonprofit housing agency in Columbus. So he came with a lot of expertise in the space. And we sort of grown from there. But in terms of funding, anybody who will offer us money? No. One of the ways we really benefit is the hospital's philanthropic team. Their fundraising helps us a lot. And so the hospital's critical raising money from private philanthropy for us. We also, the city of Columbus passed a $200 million bond levy a couple years ago. And so the city is a big funder of ours. We also take home dollars from them. But it's from various sources all over the map. Oh, I should mention that one of the biggest ways that the hospitals contributes is that they pay for all the staffing. And so one of the best things about when we raise money is all of that goes into our programming, because the hospital carries that burden for us. And so that's really valuable to people who are donating.
Great. Now, Shanti, could you touch on whether or not there's an overall definition of affordable housing? For example, is it a percentage of housing costs in a specific geographic location?
Sure. Yeah. I mean, affordable, when we talk about affordable housing in the general sense, we're talking about people who not being cost burdened, right? So that's 30% generally of the household income, including utilities, not going to, no more than that going to your housing. And what we find is, people are more kind of considered severely cost burdened if it's above 50% of their income. And so generally the affordable housing term is aiming for housing that they can afford with 30% of their income. But affordable housing in the sense of how you're putting it into planning, that can differ based on the analysis in the community of kind of what is considered attainable for the incomes and the people that you're serving. And so that can be highly customized in the planning process. But generally speaking, that's kind of the broad definition.
Okay, thanks. I'll quickly call out just a couple of comments in the Q&A here, as opposed to questions. And that is, someone wanted to flag that North Carolina is also trying to add 6 months of rental support to their, I don't know the proper way to say this, so it's 1115 waiver-based HRSN program, HOP program.
Yep,
Did I get that right? Okay.
Yep, that's the 1115. Yep.
1115. Okay, good. And someone else wanted to mention another ally, the nation's federally funded protection and advocacy agencies that provide free legal help to anyone with a disability, regardless of income. So there's one in every state, and they can be found via a new national umbrella group, the National Disability Rights Network. So thank you for those comments. This question could really be for any of our groups here. This is something that we've seen a lot of attention to in the last few years, particularly. Um, I've seen it in relation to medical issues, and that is unconscious bias. So, how are you all respectively working and bringing unconscious bias into the work that you're doing?
I can briefly just jump in and say that um, on the healthcare side, there's a large effort around uh, having diversity, equity, and inclusion and belonging strategies as an organizational strategy. And so, that's one piece of like a holistic equity strategy for healthcare partners. And so within that, often many organizations are including unconscious bias or implicit bias training within their regular training. In some cases, some states are requiring that their Medicaid plans have that explicit training, but most requirements are broad in that they want to make sure that you have a training and that you're ensuring that both your providers as well as your own employees are trained in this in the various kind of menu of trainings that are included in the DEIB bucket.
And I would echo the same. We have, of course, a health equity strategy from the Blue Cross Blue Shield Association that we've tailored to Care First. We also have Equity in Action 365. And so that's for our internal employees, where we have a week of learning. Implicit bias is a part of that. There's other topics that range when we talk about DEI and belonging. It's not just race-based or gender-based, and so really intentional about that. In terms of and then we have created modules for our providers, specifically around implicit bias, to come on, log onto our website, and they could take those courses and get CEUs. And then on the funding side of it, as a grantor, we have some diversity requirements that we have as it relates to the board and having, health equity lens, et cetera. And then we also provide learning collaboratives, and then those same modules that we do during our Equity in Action 365. It was a day, then it grew to a week, and now we're doing it around the calendar. We also invite our community partners in and share some of those resources as well. So very intentional about trying to have really honest conversations and learning and understanding that, sometimes it's not, it definitely is implicit, and sometimes it's explicit, and how do we manage both?
Okay. How do we know that your state can be approved for the waiver, or if Medicaid Advisory Committee is going to be part of this project?
Oh, you want to take this? So there's two things here. You can find out if they were approved, or you can find out if they're applying for a waiver. And this kind of segues into the Medicaid Advisory Committee. Waivers require engagement of communities and feedback before they can be submitted, and states must provide evidence of that. So typically they would work through their Medicaid Advisory Committee as well as others. Any state could be approved, but you can't just say you're going to do something and not have a plan. So there has to be evidence of a plan to meet those goals in a waiver, and they are evaluated. So while they could do it, they won't be approved unless they've done this community engagement, planning, and have something solid there. But Letitia did share in her slide, which I'm sure you'll have access to, states that have already been approved. And you can go, if you Google Medicaid 1115 waivers, it'll take you to a CMS site where you can look at, because there's all different waivers, waivers for different things. You can just dig in, play around with that, and look at what they're including.
And I just wanted to add that just what a waiver is it essentially allows a state to break the rules, the CMS rules that are currently in place for payment. So, and it's you're saying that I want to do something different. I'm going to propose something different. CMS approves it and says, okay, you can do this, but now you have to show that there's a cost and a quality outcome that comes from your approval. And the waivers that have come down around the health related social needs, this is a big deal because Medicaid explicitly never ever wanted to step into the housing space for, that's how it's been for a long, long time. And so this is the first time that there's being a waiver of kind of the rules in the standard Medicaid program that allows for us to test these out in these demonstration projects. And so just wanted to clarify that. And if you mentioned the state of Texas is where you're at, every state has different kinds of waivers. There's different motivations for those rate waivers. And so they usually kind of originate with the executive administration kind of initiating that. And so in your state, it depends, if you're in a non-expansion state, they're going to be really targeted and focused on specific populations. The broader waivers are more likely to be in states that have Medicaid expansion.
Okay. Can anyone speak to the role for CHWs in supporting this work, including reimbursement for their services?
I can jump in on that. I think this is an area we're doing some work in Chicago that's supported by the Chicago Department of Public Health around creating hubs for funding for community health workers. And the reason that is because in Illinois, the Medicaid program is creating a state plan amendment, which amends their current Medicaid plan that will allow for payment for community health workers that are connected to the clinical delivery system. So that's important to note. So not anyone who's doing community health worker work will be paid through the Medicaid program. But the reason why that's important in this conversation is that in the housing space, there are a number of folks who do a number of different roles that fit either they are community health workers or they're doing navigation, which in the states where there's waivers and where they're approving funding and payment for community health workers, there's an opportunity for housing agencies to see if the services that they're providing, with the oversight of a clinical provider, could be generating revenue for community health worker services. So it's something that I think in Illinois in particular, we're thinking about because we have the state plan amendment that's going to pay for community health workers and a 1115 waiver in play. So we're thinking about that within that context.
Great, thank you.
I would just,
I'm sorry, go ahead.
Lori, I would just add, I mean, I think in terms of participating with the fair housing process and planning process, workers have, great insight into the needs of communities and can be a part of that collaborative process. And I also think that the use of community health workers and funding their presence in communities can also be a strategy for housers and folks who are developing fair housing plans. That can really come up as part of the connections to health outcomes and connecting people to housing resources, and should really be considered as one of the ways that we can better connect across the two systems when we have these people who are in communities who already are connected to so many things. Like, what, again, to I think Letitia's point earlier, like, let's not reinvent the wheel, right? Like, we already have this network here and it can be really tapped into the advancement of housing equity as well.
That's perfect. This next question I am going to lob to Gretchen because, Gretchen, you talked a little bit about Columbus's recent, rezoning and what, what that looked like. So can you comment on what community members can do to get involved? If they don't agree with local zoning, transportation, environmental justice type issues, how can citizens get involved?
Yeah, I think that's probably really specific to your location. So I can speak to Columbus. In Columbus, we have area commissions, and it's neighbors who are on boards. It's an unpaid position that review development proposals. And 9 times out of 10, those are homeowners, generally older homeowners who have the time to commit to these types of boards. And so they generally, in my experience, come with that perspective. And those, when projects come up that are affordable in nature, most of the time those boards hear from people who are mad about it, and there aren't enough people showing up to be supportive about it. So I think there are ways to strategically show up to those kind of boards, commission meetings, city council, to have your voice be heard in a way that's supportive instead of tearing it down.
Thank you. Is there anything you want to add to that, Shanti?
I mean, I would just say, I think Gretchen answered it perfectly. Like there's processes, there's elements in the processes that are built in for people to be able to engage, as hard as it may be to navigate. I mean, from the fair housing perspective, many communities, most communities have an active fair housing center. Our members, NAFA's members across the country, engage in the process from a fair housing perspective, and can be a resource and also a place with which to engage to advance some of these goals that you may have on a personal level, to have better zoning policy, better transportation policy, advance environmental justice. So I would just encourage you, if you're not familiar with your fair housing center, to learn more about their work. And at NAFA's website, we have a tool where you can look up, kind of the local presence there. So I'd encourage you to check that out.
Thank you for that. And that actually touches on a couple of the other questions related to AFFH that are in the chat. We only have about 4 minutes left, so I don't think we're going to be able to get to all of these really, really great questions here. There was a question about what counts as affordable housing in rural areas. And I think, Shanti, you kind of touched on that a little bit in your earlier response about affordable housing. Here's one that says, we have a big crisis in Houston, Texas. People are on a waiting list to find affordable places to live and or to get into rental assistance or to get rental assistance. Is there a better way to solve this problem? Sometimes people don't have really any choices. And I'll just say that that's an issue that we see all over the country. So I don't know if anyone wants to jump in and comment on that one.
I mean, I would just say, I think it is a crisis all over the country, as Lori said. And I think we are having this conversation to really try to get at the systemic causes for that. We can do as much as we can, and there are efforts that need to happen immediately, right? There are efforts that need to happen immediately. People need a roof over their head. We need to house people. We need to get people shelter. But what we're talking about here is really coming across sectors and processes that are really addressing the systemic issues and getting at things a little bit more upstream, so we have a more longer term solution for these types of crises. So
Yeah, no, that's good. And there was another question related to that about NAFA embracing the housing first movement. And I would say that that is something that we see in conversation with a lot of our housing advocate colleagues. Let's see here. I'm curious why no one in these spaces addresses the elephant in the room, which is what actually causes housing crises and health disparities. Our system that allows people to profit off of basic needs. Yeah, that one, because it's called an elephant in the room, I thought that'd be a good one to pose live if anyone has anything to share on that.
Yeah, I mean, I could just say that that's I think exactly it. I mean, I think that we have to collaborate more. I think I was in a meeting yesterday and we talked about, somebody asked that similar question around like, what do we need? And we need to collaborate with our competitors, right? And I think that, those who work in the healthcare space, there's a lot of competitors in that space. And yes, while some of it is nonprofit, some of it is for profit. But at the end of the day, we as system partners, whatever space you sit in, we have to lean on collaboration and co-opetition, which, coming with our competitors together, and where we've seen that happen across the country, where competitors are sitting at the table to solve very challenging problems in partnership with community and centering community, we see significant results. And so I think that is a really good point, but just continues to underline the importance for alignment and collaboration.
Maybe,
Thank you for, oh, sorry, go ahead.
maybe also bringing data to it, because one area, like a big cause of financial instability, which leads to housing instability, is medical debt. It's like the biggest cause. It's unbelievable. And healthcare organizations are behind that. But we're now seeing states and localities going after that in ways recently this year that we've never seen before. So that's like a big elephant in the room. So drawing attention to the magnitude of the impact and getting leaders on this, is working in that case.
Thank you. So we've got almost all the questions. We couldn't get to all of them. We are at time. We're actually a minute over. So you see a QR code there on your screen to the action guide. You can get more information on this on NAFA's website. Again, this presentation is being recorded for later posting. And feel free to reach out to us at NAFA, and we can certainly connect you with our guest panelists and speakers today to follow up with additional questions, or if you need a little bit more information on anything that we've spoken about today. I want to thank all of our audience members for tuning in, and I would also like to thank all of our guest panelists for giving of your time and expertise on this very, very important topic. So thank you again, and have a great afternoon.
Thank you.
All right.
Good job, everyone.
Thank you. I
Bye.
didn't
Thank
thank
you.
Thank you so much. Take care.
You too. Bye-bye.